Hello guys, welcome to MedTube. So we'll see today about a very interesting and important topic called fundus fluorescein angiography FFA. So we have to know about certain terms like fluorescence and luminescence. So luminescence means spontaneous emission of light by substance that is not resulting from heat. So maybe due to any chemical reactions or due to any electrical energy. Fluorescence is that luminescence which is maintained by continuous excitation. So dye used in FFA is sodium fluorescein, which has its peak absorption at 465 to 490 nanometer, which will fall under blue spectrum of light, and its peak emission is at 520 to 530 nanometer, which is at green spectrum of light. So it is only 20% free that is available for fluorescence, and the remaining 80% is protein bound. So when we see this peak absorption and peak emission points in a graph, it will look something like this. So at about 465 to 490 nanometer there will be absorption peak, and at 520 to 530 nanometer, which will fall under green spectrum of light, there will be emission peak of the dye. So under what principle this FFA work means, the dye, that is the sodium fluorescein, will absorb blue light and emits yellow green light. So this dye after injection will present in the vessels and in the areas that are leaky. So we'll first see how it works, and then we'll go to this beautiful pictorial representation of what is the principle behind this FFA. So when white light is projected to see the fundus or retina, it passes through a filter called as excitation filter, which allows only blue light to pass through it. So this blue light is transmitted to the retina, and the areas containing the fluorescent dye will absorb this blue light and emits the green light, whereas the areas not containing the dye will reflect the same blue light that is transmitted. So both these blue and green lights will passes through a second filter called as barrier filter, which allows only the green light to pass through. So finally green light will be emitted into the camera, and the corresponding areas of the fundus can be visualized. So this same thing, if you represent in the form of a picture, it will look something like this. So consider this as retina or the fundus which we want to see. So after the injection of dye, consider this area is having that fluorescent dye. So when we project white light, this will pass through a filter called as excitation filter, which allows or splits this white light into blue light. So only blue light will pass and transmit to this retina or fundus. So the areas which are containing the dye will absorb this blue light, and it will emit in turn green light, whereas the areas which is not having the fundus, not having the fluorescent dye, will emit the same blue light which has been transmitted to them. So both these green and blue lights will pass through a second filter, another filter called barrier filter, which allows only green light to pass through it. So finally it is the green light which is reflected from the dye containing in the parts of the retina which is containing the dye can be seen through the camera. Okay. So now we'll come to the actual procedure of FFA, how it is done. So first we'll secure an intravenous access with a butterfly cannula, and heart rate and saturation will be monitored using pulse oximeter. So in children we can use oral fluorescein angiography as an alternative. So in this we'll use 4 ml of 25% of the dye, and is mixed with 30 ml of the orange juice, and is given to the child to drink. And now the subject of the patient and the photographer should be seated comfortably. Then we'll take a color photograph first, then a red free filter fundus picture is taken, and then fundus autofluorescence picture is taken. So the dye का injection के पहले we take photographs of the target eye to detect any pseudofluorescence and mismatch, if any, present between the excitation and barrier filters. So we can use like 3 ml of 20% of the dye, or 5 ml of 10% of the dye, or 10 ml of 5% of the dye. So these are the concentrations of the dye which can be used in FFA. And we will inject this within a span of 2 to 3 seconds, which is called as rapid injection, which has advantages like high concentration of dye will be present in the bloodstream, which gives us a better photograph, and it has also some drawbacks like increased nausea. So normally, ideally, we'll give at a rate of 4 to 5 seconds, which will reduce this nauseating feeling. Sorry for the poor camera focus. Okay. Coming to picture capturing. So first we'll take the photograph of the target dye at the initial time of injection and at the end of the injection. So we'll first turn off the lights, and photographs are taken at an interval of 1.5 to 2 seconds for up to 30 seconds. Then the photograph of the other eye or the fellow eye is taken, and it is captured once in 1 to 2 minutes up to 10 minutes. So the interested areas are captured initially, later the remaining areas are taken. Coming to the field of view, normally conventional fundus cameras will give a view of about 50 to 55 degree, whereas ultra wide field angiography, which uses optos and spectralis, which gives 200 degree field by optos, and non-contact spectralis will give a field of about 105 degree or 120 degree field, whereas contact spectralis will give a field of about 150 degree. So this ultra wide field view can be used to visualize the peripheral retina at a stretch in a single frame. Coming to the side effects of the dye. So most common side effect is the yellowish discoloration of the urine, skin or breast milk, and in about 5% of cases we can see nausea, which begins in 30 seconds after the dye is injected, and it can last for about 2 to 3 minutes, and it is more with rapid injection of dye, that is if we inject the dye within 2 to 3 seconds. Whereas in 0.3 to 0.4% of cases we can see vomiting, which begins after 40 to 50 seconds of the injection of the dye. So how to prevent this vomiting and nausea is by restricting the food and water intake 4 hours before the injection of the dye, or we can use promethazine tablet 25 to 50 mg 1 hour before the injection, or we can reduce the rate of the dye injection. So another side effect of the FFA can be vasovagal shock, which includes bradycardia, hypotension and lightheadedness. That's why we have to monitor heart rate and saturation with the help of pulse oximeter, and make the patient to lie down with foot end elevated. And in severe cases we can give IV atropine 1.2 mg stat and IV fluid bolus. And other reactions or side effects can include reactions due to allergy to the dye, that can be mild or severe. So mild conditions can have symptoms like hives and itching, which starts after about 2 to 15 minutes of injection, and it can subside in few hours. So in this we can use IV phenidamine or antihistamines for that. And in severe cases we can see bronchospasm, anaphylaxis, hypotension and edema of the larynx. So in this we can use systemic steroids and epinephrine. So the dye can also get extravasated into the tissues, which can cause local tissue necrosis, thrombophlebitis and subcutaneous granulomas. So the cause of death in few reported cases during this FFA are severe allergic reactions, that means these, and acute pulmonary edema and hypotension in patients with pre-existing CVA or coronary artery diseases. So coming to the drugs which can be given in some side effects. So when we have hives or itching, we can use phenyramine IV, and when we have vasovagal shock, we can use IV atropine, and when we have very severe allergic reactions like bronchospasm and anaphylaxis, we can use systemic steroids like hydrocot and adrenaline. So there are some contraindications to this procedure. That is, if the patient is a known allergy to the dye, or in especially first trimester of pregnancy, and in severe renal diseases, because to prevent contrast nephropathy, and in patients with recent MI, CVA, or with angina, unstable angina. Okay, so now we'll see some terminologies in FFA, that is hyperfluorescence and hypofluorescence. So hyperfluorescence, as the name itself indicates, it will be more, so the dye will be more. So this hyperfluorescence can be due to the actual dye can be more, that is due to leak or pooling or staining, or the dye is normal in quantity but there is better visibility of the dye, that is it may be due to window defect. Same like that, conditions can cause hypofluorescence, that may be due to actual lesser quantity of dye, that is due to non-perfusion, or the dye can be in normal amounts but there is poor visibility of the dye. So that condition may be due to block fluorescence due to any abnormal structures or masses. So coming to leak, first of all, so leak indicates that there are new vessels with poor blood retinal barrier, or blood retinal barrier is disrupted due to any inflammation or any due to structural damages. So in this, both size and intensity of the leak, of the dye, will increase with the time. You see here, they will increase with the time. So for us to confirm that there is a leak present, we should have at least 2 frames of the FFA pictures. So coming to pooling, so pooling and staining are essentially the same. The only difference between these two is pooling indicates that the dye is leaking into a well-defined space, whereas staining, as the name indicates, it will stain a tissue. So there is a leak of dye into a tissue, like into sclera, drusen, or into any scar that is present, etc. So in both of these things, size will remain the same. Only the intensity will increase as the time increases. Now coming to window defect. So window defect indicates that it is due to better dye visibility due to absence of structures which can block the choroidal fluorescence. Example, due to loss of retinal layers or retinal pigment epithelium, like in cases of retinal hole, etc. So in this, the size will remain the same, whereas the intensity will increase initially and then decrease. So coming to causes of hypofluorescence, that may be due to non-perfusion or due to blocked fluorescence. So for us to differentiate between these two, we should need a color photograph. So this non-perfusion indicates loss of circulation, whereas blocked fluorescence, as the name itself indicates, that there is presence of substance which obscures the normal fluorescence. Now coming to phases of FFA. So the first phase is called choroidal flush. This is due to appearance of dye in the choroidal circulation, and it denotes arm retina time. That is the time taken for the dye to travel from the injected area, that is mostly the arm area, up to the retina. So in young individuals it is about 10 to 12 seconds, and in old individuals it is about 12 to 15 seconds. It is seen as irregular faint hyperfluorescence and scattered islands of delayed filling. In 30% of population, coeloretinal artery can be seen in this phase. Coming to second phase, which is called as arterial phase, it is seen in 1 to 3 seconds after choroidal flush. In this only the arteries are filled with the dye. So the third phase is called transit phase or AV phase, in which arteries are entirely filled with the dye, and the dye will travel slowly towards the veins, that is through precapillary arteriole, then to capillaries, and then to postcapillary venules. So in this, laminar flow is seen. We'll see how it is can be seen. So consider this as a capillary. So in this, periphery of the capillary will contain hyperfluorescence, whereas center of the lumen will have hypofluorescence. That gives us a laminar flow. Coming to the venous phase, which can be early or late. So the early venous phase contains widening of this laminar flow, whereas the late venous phase will have complete filling of the retinal vein. So coming to the late phase, which is the final phase, also called recirculation phase, it is seen beyond 30 seconds when the fluorescence starts to fade. So coming to the normal findings which we can see in an FFA, normally in a normal retina or fundus. So we can see foveal avascular zone, which is seen as hypofluorescence because it is avascular. Basically retinal vessels are not there, so it will be hypofluorescence. So the reasons for this foveal avascular zone, as we said before, is due to absence of retinal vasculature, that is non-perfusion, and the RP cells are tall, and there is macular xanthophyll. Both can block the fluorescence and can lead to hypofluorescence, and also this macular xanthophyll will absorb the incident blue light. So this foveal avascular zone can be seen best after 25 to 30 seconds when there is peak fluorescence concentration in retina. Another normal finding seen in FFA is staining of disc margins and lamina cribrosa. It is seen in late phase. So the reason of this finding is the dye which leaks through the fenestrated endothelial cells in choriocapillaries stains this sclera and lamina cribrosa, so that we can see the staining in the corresponding areas. Thank you for staying till the last. Thank you. Hope you enjoy this video. Thank you.